Hi friends, welcome to the part 2, the interpretation part of my spirometric interpretation guideline video series. And in this part, we will take it forward from the first one. So in case you haven't seen the first video, you may want to look back and see the first part of this video to understand what is the new terminology that is used to interpret spirometry. When we do lung function assessment, we perform airflow measurements, lung volume and gas transfer measurements. The main area of this video would be around the airflow measurements or the spirometry. I would be giving the screenshot of the charts for the flow volume and the gas transfer as well, but that would be out of the scope of this video and we can have more videos on that later. But basically, whichever measure you want, we are trying to ascertain the patterns of altered physiology, and repeatedly the guidelines mention that PFT alone should not be used to diagnose a condition, and it's very important to repeatedly assess and see the trend as in the trend graph to assess meaningful deviations in a patient's individual results. So the measured variables include airflow through inspiratory, expiratory flow volumes, the lung volumes and capacities, TLC, RV and FRC, through the body box, and alveolar capillary gas transfers measured by transfer capacity of lung for carbon monoxide, also called as diffusion lung capacity, and these can be assessed via lung function testing. We'll be concentrating on spirometry now. This is the summary of the 2005 and 21 ATS ERS technical standard. We've spoken about it in the previous video. We're looking at the lower half of it now, and we'll be looking at the interpretation of the severity of lung function impairment and the classification. So let's zoom it and see what are the changes. So in 2005, when we used FEV1 for obstruction or restriction, we divided into two: mild, moderate to severe, severe and very severe categories. Mild being FEV1 more than 70, 60 to 70, 50 to 60, 35 to 50 and less than 35%. And similarly with DLC also there was a separate grading of mild, moderate, severe being 60, 40 and below. What has changed now is that for all measures, whether it's TLC, whether it's FEV1 or FVC, we will prefer to use Z scores or Z scores, and they are graded as mild 1.65 to 2.5, moderate 2.5 to 4 and severe 4.1 and less. So this is the new grading criteria using the percentiles, using the standard deviations. Also, the classification of physiological impairments earlier were airflow obstruction being a lower FEV1 on FVC ratio, and lung volumes were used to detect hyperinflation and air trapping, and restriction being the TLC being less with a normal ratio or mixed, both of them reduced. Now again, airflow obstruction is still a reduction in FEV1 FVC ratio with the use of lung volumes, but there are new terminologies and new classifications such as dysynapses, non-specific pattern, prism, and restriction has also been further categorized into simple versus complex restriction and mixed restriction. So this is a lot of change in terminology, and we'll be talking about this change in the coming few minutes. One important change that we spoke about in the last video was the determination of bronchodilator response, and we'll be applying it to understand how it has changed. Basically, the interpretation of PFT focuses on these values and these deviations, and they recognize these patterns of altered physiology. So, what are the ventilatory impairments that we can diagnose and classify? We've all been labeling them as obstructive or obstruction, restrictive or mixed. It's important here to emphasize again and again that in normal lungs, your airflow is determined by the expiratory driving pressure, the passive recoil of the expiratory muscles, and the elastic recoil or the viscoelastic properties of the lung. Whenever we are assessing airflow, the airflow obstruction may be caused either by a physical obstruction of a central airway or an intrapulmonary obstruction. So in such cases, the peak expiratory flow, the forced expiratory volumes, and the ratio may be variably changing. In restrictive ventilatory impairments, there may be an impaired expiratory muscle function or a neuromuscular impairment or a chest wall impairment, and so here almost everything from the peak expiratory flow, the FEV1, the FVC may also reduce. So whenever we talk about classifying any impairment, it's important to note that it is to be classified as a ventilatory impairment. So this is not diagnostic of an obstructive disease, for example. So an obstructive ventilatory impairment does not equate to COPD or asthma. It is an obstructive ventilatory impairment which could be caused by either a central cause or an intrapulmonary cause or other causes. So when you report a PFT, it's very important to mention the right terminology as an obstructive ventilatory impairment, a restrictive ventilatory impairment, or a mixed ventilatory impairment. What we define as obstructive ventilatory impairment is the ratio declining below the lower limit of normal, which now we understand from our last video is the 5th percentile of a normal population. And the problem exists when the GOLD guidelines and the GINA guidelines talk about a fixed value to define an obstructive ventilatory impairment vis-a-vis the newer guidelines talking about not using a fixed value. So it is to be remembered that for means of interpreting any patient's report, pulmonary function test is not diagnostic of a disease but of the physiology. When you are trying to diagnose COPD and you've ruled out all the other factors and assess the severity according to the GOLD guidelines, you could use the pulmonary function test report values to interpret the GOLD severity, but in no way a lung function testing report will be indicative of the diagnosis, rather it will be of the physiology. Let's start interpreting now. So whenever we perform a lung function test, we follow a flow chart to assess what is the change that is happening amongst the variables. We always start with assessing the FEV1 on FVC ratio first. Is the FEV1 on FVC ratio more than 5th percentile or more than the lower limit of normal? Whether it is above the lower limit of normal or below the lower limit of normal, keeping that in mind, the next parameter to be assessed is the FVC. And once you've assessed the FVC being high or lower than the lower limit of normal, we would further go on our flowchart. So if your ratio is normal and the FVC is also normal, then this is essentially a normal spirometry. If your ratio is not normal and FVC is also not normal, then there's possibly a mixed disorder, because not only the FVC, the forced vital capacity, being affected, but also the ratio is also being affected. Now there come two complex situations where your FEV1 on FVC is normal but your forced vital capacity is not normal. Again, it implies possibly there will be a restriction, but we also have a non-specific pattern that can exist here, and we will need lung volumes to confirm. If your patient does not have a normal ratio but his FVC is normal, then we can say that there is an obstructive ventilatory impairment. Keeping this in mind, there are several deviations from this rule, and one of this, the new term, is dissynapsis. So what dissynapsis means is that in case we take a healthy individual, and we get a lower FEV1 on FVC ratio, along with an FEV1 which is nearly normal, then we would not know what to interpret out of it. So this patient's forced vital capacity is normal, this patient's FEV1 is normal, but this patient's ratio is reduced. In such cases, the problem may actually be an unequal lung growth, unequal growth of airway and parenchyma. So there may be a high forced vital capacity but a lower residual volume, or in these cases there may be an obstructive pattern depending on whether this patient priorly had an obstructive disease, and now if we do further testing, say we perform a bronchodilator response, or we do a diffusion lung capacity or a gas exchange evaluation or a muscle strength measurement, we may be able to find out whether this is a normal patient or there is a propensity for an obstructive lung disease. Earlier, whenever the ratio was normal but was low but FEV1 was normal, it was thought to be normal. But now with data we have seen that these patients may actually be having an obstructive lung disease in the future, or there may be a problem. So here these patients must undergo further testing. Another new terminology is the non-specific pattern. Non-specific pattern means here your FEV1 is low and your FVC is low, but your ratio is normal. So here the reduced FVC or FEV1 with the normal ratio and a normal total lung capacity has been found. So since the total lung capacity has ruled out a restrictive pattern, so this becomes a non-specific pattern. So this was earlier thought to relate to airflow occlusion or collapse, but it has now been seen that even if your patient does not do a good effort or does not inhale or exhale completely, you may get a falsely low FEV1 or you may get a falsely low FVC. So your ratio is normal but FEV1 or FVC is low. It may be because of patient's own effort, and so here the flow volume curve will change. We'll be looking at this example later, but this flow reduction can cause a change in the flow volume curve which becomes more concave, and your volume time curve also helps to differentiate whether the patient was giving a good effort or not. So this pattern or the non-specific pattern may be seen in a lot of your patients, and sometimes it may be an indicator of a reduced effort, and sometimes it may be an indicator of a restrictive impairment or an early small airway collapse, in which again the FVC can reduce because of the small airway collapse before the FEV1 FVC ratio really goes low. So these are similar to what would happen in PRISM, which has been defined by the Gold guidelines. Preserved ratio, impaired spirometry, where the ratio is preserved but one of the values is lower. So these patients definitely need a follow-up. These patients have to be seen over a period of time to see whether they have an overt obstructive or restrictive disease, and they cannot be passed off as normal or just a poor effort sometimes. So this non-specific pattern may also need further monitoring and further testing. This is how the ventilatory impairments have been classified according to the newer guideline. This works best when you have an example and you check these values on each example. Essentially, whenever you have an obstruction, we've already said that the FVC is normal, the ratio may be low, and the FEV1 may be low. If there is a restrictive impairment, the ratio may be normal or high, but the FVC will be low. You may also have a lower FEV1. In the non-specific pattern, there is a preserved ratio. Remember it with PRISM. There is a preserved ratio but impaired spirometry. And in patients where there is muscle weakness or suboptimal effort, you may get this similar to the non-specific pattern. If a patient has dysynapses, his FEV1 and FVC are normal, but here his ratio reduces. So it's just opposite to what a non-specific pattern will have. These are the ventilatory impairments described in the new guidelines. So the obstructive impairment, the restrictive impairment, and the mixed impairment. Let's look at some flow volume loop examples which are given. If you look at the first one, this is a normal flow volume loop with good expiration and inspiration, a good forced vital capacity. Look at example number 2. Here the vital capacity is normal, but if you look at it, then there is some concavity here. There is a reduction in the volume during expiration, so this could be obstruction. This is a typical dog tail appearance, a typical obstructive pattern. In addition to the reduction in FEV1, you will also see some reduction in FVC in a severe obstruction. We come to this one. Here there is almost a flattening of the inspiratory loop. So this is a variable extrathoracic obstruction defined even in the previous technical standards. So this is a variable extrathoracic obstruction. Coming to this one, you see the flattening of both expiratory and inspiratory. We all recognize it now. It's a fixed obstruction of the large or central airway. This is a newer pattern in this guideline where you can see there is an irregularity. So the inspiratory curve, if you see, it shows a concavity here, and this is the expiratory curve. So this typically would happen if you will have a unilateral bronchial obstruction. So while this patient is inhaling, one is normal and one is blocked. So you may get a partial kind of a pattern, a unique pattern. This is typically restrictive. You see a reduction in FVC but a normal FEV1, and this has to be a mixed because you see the severe obstruction but you also see a reduction in the forced vital capacity. Coming to the classification now, determined by lung volumes. So this is out of the scope of this talk. We can discuss lung volumes in the future talks, but I'm just going to briefly show you what the guidelines have given mainly. So if you're preparing for an exam, you can go through this. So again, when we do the lung volumes, the impairment in TLC, FRC, RV can be used to assess further variations. We can classify them into large lung obstruction, simple obstruction, complex obstruction, mixed disorder, muscle weakness related, suboptimal effort, and obesity. Let's look at the flow chart. The flow chart here to approach the lung volume begins with the TLC. They begin with the total lung capacity, and we determine whether restriction is present, whether on the basis of whether the TLC is low or the TLC is not low. Right now, if there is restriction which is present, then we assess the relative functional residual capacity. Now the functional residual capacity or the residual volume to the TLC, so the RV TLC ratio or the FRC TLC ratio. If the FRC TLC or the RV TLC ratio are elevated, then we have to find out whether there is an airflow obstruction. For that, we need our FEV1 on FVC ratio again. So we go back to the FEV1 FVC ratio. Now there was a restriction and there is an obstruction, so this has to be a mixed disorder. But if the FRC TLC and RV TLC was not affected, then it's a pure restriction. Now in certain circumstances, if obstruction is present, it can also be either a complex restriction or a mixed disorder. So this complex restriction is a new term which tells us that there's more than one process occurring, and more than one process is lowering the FVC out of proportion to the reduction in the total lung capacity. This can happen because of obesity, it can happen because of a neuromuscular disease, and so this complex restriction can be found out using this way. If your FRC TLC and your RV TLC were normal, but your TLC was reduced, then we are sure that it is a simple restriction. Now coming to the other part, now if your TLC is normal, we've ruled out restriction. Now if the lung function, if the lung volumes are normal, or the individual has a good lung expansion, as we can say, then either this patient is hyperinflated. And how can we find out that? Is by noting the TLC and by noting the FRC or the residual volume. Now if your patient's TLC is high and there's a possible hyperinflation, and you do the FRC TLC or RV TLC ratio which is high, then this is a pure hyperinflation. But if this is low, then this patient probably has some problem like emphysema going on. Again, when your patient's TLC is not high and your FRC TLC or RV TLC ratio suggests that is also not high, then this patient has a normal lung volume. So this is a good flow chart. Again, you can keep it with the spirometer and assess it side by side. Another alternative index is the DLCO, and when we approach DLCO earlier, we would have three categories: 60, 40 for normal. So here again we assess if the DLCO is low or high based on the upper limit and lower limit, which is again the 5th percentile here. And a high DLCO, normally a diffusion being high, could be because of high pulmonary blood flow, there could be a shunt, there could be an increased hemoglobin, or there could be free hemoglobin like in an alveolar hemorrhage. So basically, to understand the cause of that, we assess the alveolar volume and we assess the transfer coefficient KCO. If the alveolar volume is normal, then probably the alveoli are okay, and so there is a pulmonary vascular impairment going on, right? Or there could be emphysema and preserved lung volume or anemia. If the alveolar volume is low or normal, then there's typically problem in the alveolar capillary structure. It could be emphysema, it could be an ILD, and in that case you would want to see whether this patient has a loss of alveolar capillary structure or there's a loss of lung volume, such as in a lung resection or a palsy or a neuromuscular dysfunction. So these flowcharts are good indices, and they help us ascertain the further cause. There are a few alternative indices. Much of them are not used frequently, but in adults FEV6 can be substituted for FVC. There could be inspiratory capacity and there could be airway resistance measurement. These are the lung function indices to distinguish extrathoracic and intrathoracic obstruction. Again, these can be helpful to assess further whether extrathoracic obstruction is fixed or variable, or it's in the intrathoracic region. Coming to the final part and concluding the talk with an example. So here you see an example of two different reports of the same patient. This is the 2005 recommendation and this is the 2021, and this is the upgraded report. So visibly there's a huge difference. You get more Z-score values pre and post. You get a graph where the patient is on the Z-score based on the lower limit of normal, and there's also a trend graph. So it's good to remind ourselves again that a Z-score normal is more than minus 1.645, mild is minus 1.65 to 2.5, moderate and severe. Let's take the example. So let's look at this patient, and this is the newer way the report looks. So if you look at this patient, his FEV1 and FVC is less than the lower limit of normal. Now this patient also has a reduced FVC, and this patient also has a reduced FEV1. Let's look at the Z-scores here. The Z-scores for both FEV1 and FVC are minus 4.36, so definitely the severe. Let's try and ascertain the post bronchodilator. So post bronchodilator has to be calculated here. So let's look at this video here. We want to assess the post-bronchodilator value. This patient's, we calculate post-bronchodilator response by seeing his post value of FEV1, here 1.22, and we would subtract it from his pre-bronchodilator value, which is 1.14. We will divide it from his lower limit of normal, which is 2.40, and we'll take a percent of this. So this comes out to be 0.08 by 2.40, which actually corresponds to 3.33%, and 3.33% is definitely less than 10%. So this patient does not have an adequate bronchodilator response. So this is how we can calculate, and it has much changed from the previous reports that we used to have. It also gives us a detail of the Z score, where the patient is deviating, so a good graphical display and a visual display as well. I thank you very much for watching my channel. Please share the channel with your friends. Happy reading, and see you with another video.